So our first panel of a few panels that we're going to have of esteemed panelists is a wonderful group of folks who are helping move the research agenda around ACEs forward. Again, I'm going to ask you to refer to the bios in your program book, but we're very, very fortunate to have 6 panelists. Dr. Hayes Grudo from Oklahoma. You can raise your hand. Dr. Heather Larkin from New York, or New York, as I used to say. Dr. Christine Bethel, who can, yeah, please come up, from Oregon. And then 3 of our researchers are going to tell us the Philadelphia story from the Philadelphia ACE Task Force, and that's Dr. Lee Pachter, Mary Harkin Schwartz, and Dr. Roy Wade. First, we're going to have Dr. Hayes Grudo speak, and if we can load up her slides, it looks like they're done. Great. Dr. Grudo.
Thank you.
So if you need this, it's green, and it points that way.
Thank you. Good morning. I haven't looked forward to a conference this much in maybe 25 years. Yeah, a lot of people feel that way. To get to speak to a group of people who are doing work that I admire and respect is not something that happens every day in a person's life, and I'm very thrilled to tell you about what's happening in Oklahoma because we're really, really excited about the direction that the ACEs model is taking us. I know what Dr. Anda means when he talks about the Trojan horse. I'm a developmental psychologist who spent almost 30 years in schools of medicine, trying to advocate for this larger model as it affects health. And suddenly we have the ACEs model, and it got easier. So let me tell you about ACEs in Oklahoma first of all, very briefly. There is a historical, long, sad tradition of adverse childhood experiences in Oklahoma. It's barely 100 years old. I didn't grow up there. I've learned about it in the last 5 years. This shows the trails of tears. There was not one trail of tears, but many, many Native peoples were unceremoniously uprooted from wherever they had spent forever and marched across the south and southeast to Oklahoma. And sometimes when they got there, they found that they lost that land because there was oil underneath it and they were moved again. So that's the first thing you probably know. You may not know it's also Tulsa, in fact, is the site of the worst race riot in American history. We don't even know how many people were killed. In June of 1921, at least 300. So first thing I learned about Tulsa when I decided to move there was the race riot. If you Google it, you will find it. You probably know about the Depression and the Dust Bowl. You may not know that we lead the country in female incarceration, and we have a high rate of homelessness, meth abuse, a lot of problems. So the ACEs study came along in a nice way where I am, 2 different directions. We got to look at it last summer, both in our clinic population, in patients who we see in the departments of internal and family medicine. We had a total of about over 600, almost 700 patients and parents from early childhood centers that we interviewed in 2 separate studies. The data are why I think I was invited here. So I thought I would show you data, and then I'm going to tell you, more importantly, what are we doing with this data? So first of all, demographics. You can see that our 2 populations are similar in many ways. They're predominantly female. They're poor. They have a high rate of high school dropouts, not a lot of education, and they're very mixed in terms of ethnicity. Most people think of the Midwest, including Tulsa, as being kind of white, and it's maybe not so much as we think. The big difference is our clinic populations tended to be older. They had access to health care, although you'll see that was spotty, and they are not so healthy. Here is the ACEs data for our clinic populations. What strikes you immediately? Well, what struck us immediately is that 30% of our clinic population had an ACE score of 5 or more. This got everybody's attention. And so we looked at the individual ACEs items, and we saw very high rates And these are people who are admitting this to a graduate student or a medical student in a white coat with a clipboard while waiting for the doctor to come into the exam room. These are the ACEs data for our parents at Tulsa Educare. If any of you are familiar with Educare, I'm sure our friend from Nebraska maybe a few other places. It's kind of a Head Start on steroids. It's a very high-quality early childhood education program, sometimes qualifying for a Head Start, early Head Start money, sometimes not. But we have 3 Educare centers in Tulsa, and we surveyed the parents last summer also, and we had a much lower rate of ACEs. And we think this is probably an artifact of the way that we surveyed them. We surveyed them, they did a self-report off by themselves in a busy early childhood center. So I think there's some underreporting here. But it didn't really matter. Like someone said, we minimize the trauma with this measure, but we still get outcomes. So these are the data, which I'm not going to pour over because you've seen these data, whether it was from the Netherlands or Spain or New York or San Diego. The data hold up that the lower the ACE score, the lower the rate. These are Z-scores. All of these outcomes are on health items are transformed to Z-scores so that you could measure them across the same item, regardless of the scale. The lower the ACE score, the lower the risk of a problem. The higher the ACE score, the higher the problem, whether it was heart disease, overall health, mental health, substance abuse. Intimate partner violence and PTSD were very prevalent, and this is our clinic population. We had 70-year-old women crying, telling a young graduate student that they had never told anybody this before, because nobody had ever asked them this before. These are our parents. Again, this one is a 0 ACE score, an ACE score of 1, or an ACE score of 2 or more. And you see the same measure, whether or not it's underreported or not, whether or not they didn't own up to an ACEs experience. We still see the same relationship in terms of number of ACEs and all these various health problems that we saw. One of the pieces of data that surprised us, we asked them about access to health care, because we hope at some point we'll actually have universal access in Oklahoma, even though there's tremendous resistance against it by our governor. And sure enough, we found that the higher the ACE score, the lower the access to health care. So healthcare barriers, we had a list of healthcare barriers, everything from I've not gone to the doctor because I didn't have money, I went to the emergency room because I didn't have money, I have medical debt, I've taken out a payday loan to go to the doctor or to pay for medical. And again, the higher the ACE score, the higher the obstacles to care. So not only do they need more care, but they also have more obstacles to care. We also asked them about their experiences as a child going to the doctor or to the dentist regularly. And like you might expect, the higher the ACE score, the less likely they were to have seen a doctor regularly. I think this has profound implications because you can't just provide care to people who've never gone to the doctor as part of what you do. You go to the emergency room. You just don't have that in your behaviors. So we saw from our data a clear and significant pattern that replicates pretty much what everybody else here has found. The higher the ACE score, the more health problems, both physical and mental. We also found a history of poor access to care. The question we wanted to know is, what can we do about it? And we focus on these impairments that you heard so beautifully described this morning. To neurological development, it affects the ability to relate to others, to self-regulate, to tolerate negative thoughts and emotions, and to focus your attention and develop working memory. So all of these things are why we develop adverse behavior problems as a result of adverse childhood experiences. We smoke, we drink, we have unprotected sex, not we literally, but as a nation. And that leads to disease and disability and early death. So you know this model. And you know, I'm so glad Dr. Garner talked about toxic stress. We know that one of the things that makes this toxic is the lack of socially and emotionally supportive relationships that buffer that stress. So in 2008, we developed something called the Tulsa Children's Project with Jack Shonkoff and Bill Beardsley and myself and a whole host of others. And our model basically says we have all these children in Tulsa Educare. They're in a high-stress, high-toxic, potentially toxic environment. They come into Educare, and that's a supportive system. But what do we know about Head Start and Early Head Start? We know that many of the teachers come from the same environment, so we find the same high rates of depression and toxic stress in them. So we thought, well, let's try to beef up the supportive relationships that surround these children, and that would be both the teachers in the system and the parents. And we'll focus on social emotional health because those are the skills that build everything up, whether it's a teacher or a parent or the children. And the short-term outcomes is we think we'll see healthier, more competent children. The long-term outcomes is a reduction in this intergenerational poverty. I'm going to share with you what we learned just from the teacher side. I could do a whole other talk on the staff side. Did I say teacher? I meant parent, sorry. So EduCareers is what we developed. We call it EduCareers to recruit parents to a program that will help them achieve economic security through adult education, might be ESL, GED, or it might be career training. We think what happens is you have these, this is from Bruce McEwen's allostatic load paper in the New England Journal of Medicine. You have this allostatic load, this constant rate of high stress or this toxic stress. What happens to a child growing up in that? Well, instead of developing executive function skills, they develop executive dysfunction, just like we talked about earlier. They do poorly in school because they can't focus. You don't learn your multiplication tables when you're always on high alert, waiting for the other shoe to drop. And what happens to kids who don't do well in school? They drop out, they get pregnant, they have terrible earnings potential, and we've now started this cycle all over again with a new generation of ACE-affected adults. So we said, let's break this cycle by taking these parents, most of whom have dropped out of school, don't have the ability to make money, help them develop some skills that will help them to achieve a higher earning potential and some life skills in the process. And we called it EduCareers. And we're just going great guns. We are doing so well, we think. Let me get to the next slide. This is our graduation of our first group of cohorts. 9 out of 9 are now certified nurse assistants. Our second group of cohorts, 12 out of 12 mothers, are now certified nurse assistants. And we think, oh, we've nailed this. You know, social workers, developmental psychologists, labor economists, we've designed something that really works. And then what happens when they go to the next level to become LPNs or RNs? It falls apart all over the place, multiple times, and now we face the risk of re-traumatizing people who failed many times before. We're in trouble. So last year we said, we've got to look at this more carefully. So we actually assessed their ACE scores at that moment. We did some other assessments like the brief, the measure of executive function, and we realized we were guilty of what most people are guilty of. We were treating the chronic disease and the problem behaviors. We were not treating what underlies those problems, the preparatory interventions that are required so that they can benefit from this supportive work we were doing. So instead of just having these programs available to them, Workforce Investment Act funding, all these different career things, we are now giving them mindfulness-based stress reduction. There's a whole literature on how this addresses the exact neurological deficits that lead to the social, cognitive, and emotional problems that we see. We're also adding something called CogMed after they complete the 8-week MBSR program. And then we thought, how does this relate to parenting? If it relates to their ability to sit in class or to get to a rotation, a clinical nursing rotation on time, well, we measured ACEs, and what I love about this is, and this is my last slide really, is that we collected ACEs data, Educare collects parent life stress and parent-child dysfunction data, and the teachers actually measure the child's social emotional development with the DECA measure. And everything is related to everything else in the correlation model. But then when we actually do regression analysis, parent ACEs do not directly predict child social emotional development anymore. It is not a death sentence to have a high ACE score. What is a death sentence to child development in the next generation is not getting out of this chaotic, crisis-filled environment and developing a poor relationship with your child. So we are now looking at this model for parenting as well as for health behaviors and developing interventions that will promote the effectiveness then when they get to parenting programs. There are some already out there already. The attachment-based programs are dealing with this on a direct level. But we really feel strongly that the beauty of the ACE model is in its intervention potential, which we're really just starting to see. Thank you very much.
Hi, my name is Heather, and it's really an honor to be here with all of you. I work primarily with social service agencies that are looking at, or that are beginning to develop ACE-informed programming, and really that's called for more, it's a call for a more whole person response, as agencies are recognizing that we've been treating the consequences of accumulated adversity and trauma, so mental health problems, substance abuse problems, and other health risk behaviors and serious health problems, as though they're separate issues when they're not. There's this movement towards more increasing collaboration and integration, really even looking at the whole organization and the whole community in terms of how do you respond effectively to adverse childhood experiences. And I'm really glad to have the chance to talk with you a bit today about what I see as some of the next steps in research. So when I back in 2006, what I saw as a need at that point in terms of next steps in research was to raise awareness among people who are working in social services of the ACE study and the implications for social services in particular. Because once you start to connect the dots from the original ACE study and you see that people who have ACE scores of 4 or more are more likely to have multiple co-occurring challenges, and then you look at some of our research in the social sciences that shows that many of the population groups we talk about as though they're disadvantaged or vulnerable population groups, maybe what's going on when we look at the numbers and see these are people who have more multiple and co-occurring challenges, is that a way to talk about this is high ACE score groups. And we do talk about high risk groups, but maybe that's been high ACE score groups. So back in 2006, I designed this study to look at the prevalence of adverse childhood experiences among people experiencing homelessness. And no surprise, more than half had ACE scores of 4 and more. What was also interesting was that categories of ACEs predicted some of the prior service use. So maybe there's opportunities to address some of the individual vulnerability to social problems like homelessness, as well as to some of the later life high-cost health consequences by developing more ACE-informed kinds of programs in social services earlier on. So other next steps then, so agencies who have learned about that data have started to look at, okay, well, what are the implications for social service delivery? And there's this movement towards more collaboration, movement beyond fragmented or categorical systems of care to really kind of plugging into a bigger picture and seeing how different professional skills can be complementary with one another, working together towards a more comprehensive response. And so ACE-informed programs were starting to develop in Albany, New York, the capital region of New York, for example. There's actually a group of agencies which has developed a coalition, an ACE response coalition, that includes agencies serving high ACE score youth in residential treatment, all the way to homeless services and older adults experiencing co-occurring disorders. And all of these agencies are moving towards a more comprehensive response that's recognizing how all of the interventions and services and processes within the agency are working together within a larger continuum of care to hopefully have a more powerful impact in the community. And in addition, this movement towards a more holistic approach is they're realizing that there's a need for developing like a culture of recovery or a restorative context within which services are delivered and strengthening social networks within and across agencies. So as we start to make those kinds of movements in practice and programs and also policies to support these endeavors, then next steps in research include, well, how do we actually carry out research that's comprehensive on these more comprehensive or holistic community and agency responses? So one thing that I've been looking at is how do you design more team-based research looking at outcomes of ACE-informed programs or even maybe ACE-informed communities. Also, and in addition, next steps in looking at, we know, for example, from other research that social networks, that health behaviors can be contagious within social networks. So can recovery behaviors be contagious, for example, within social networks? That would be another very interesting next step in research. So there's the integration of the ACE study with related research that agencies are starting to look at. So understanding the ACE study and then understanding that there's other research that informs interventions and services dealing with different types of consequences that we now see associated with ACEs. But as I said, now there's a need to look at, as we have more ACE-informed programs, explicitly ACE-informed, then how do we start to look at the impacts of that in a more comprehensive way, where we look at how interventions are working together and even maybe how agencies and communities are working together. And I think that would be team-based interdepartmental research looking at outcomes. And that would involve multiple methodologies. Also, in terms of looking at cost savings, while we have some research from Heckman and Kruger and Becker, I think, that show that the early investments have high payoffs, I think we need to look at partnering with economists to look at the cost savings associated with increasingly ACE-informed programs as we take this more collaborative and integrative public health approach in communities to partner with economists and looking at, well, what are we actually seeing in terms of cost savings, in addition to looking at, are we breaking the trajectory from high ACE scores to these high cost consequences down the road? So the Hearts Initiative is this group I told you about in the capital region of New York, where we have a number of social service programs working together. Hearts stands for Healthy Environments and Relationships That Support, and what they're doing is actually looking at how do we strengthen these social networks within and across agencies, hopefully enhancing the impact of more cohesive services within the agencies and across the entire system. Really a whole organization, a whole system response for a more powerful impact in the community. And this has involved looking at how do each of the services and interventions within programs connect to preventing ACEs or ACE consequences in one way or another, so that those services are more cohesive and integrated. But then, as I mentioned, also looking at, can we enhance the impact of that by creating a more restorative context? And leadership, we're seeing, is very important, because leadership sets the tone and the example for a culture that supports workers in preventing their own vicarious traumatization and burnout, so that they can contribute to the creation of healthy social networks or a culture of recovery through their own attitude and behaviors, setting an example of relationship building and role modeling for the people that they serve. So that's another next step in research that I see as really important, is looking at interventions to support leadership development, leadership capacity in implementing these more comprehensive whole person approaches for ACE response. So building the community capacity has involved workforce development. That means not only building the skills of the staff, but actually looking at how do we support the self-care of the staff to prevent vicarious traumatization among the staff who are creating the restorative context within which the services are provided. So you see, it becomes, everything's interconnected, so it becomes a bigger picture, it's more comprehensive, and then researchers kind of need to catch up with that too, in terms of looking at, well, what's a comprehensive research approach to evaluating outcomes based on unique combinations of services and interventions with local resources. And educational presentations and policy advocacy. Another important next step in research, I think, is the policy advocacy piece, because a number of agencies, their first step in developing ACE-informed programs is utilizing the ACE research as a policy advocacy tool to educate policymakers and funders about the reasons why programs need to be developed in a certain way to respond to the characteristics of adversity and trauma among the clients that are served. So then there's the opportunity to do research and looking at, well, what are the impacts of the ACE research on policies, and then the impact of the policies on the programs. I mentioned the website aceresponse.org if you want to look at some of the examples that we've posted of developing ACE-informed programs and policies, and it does need to be updated. A doctoral student will be working on that this summer. The other next step, I think, for research is really recognizing the importance of integrating research and practice wisdom. That, we've got the data that we want to bring forth, and then agencies are looking at, okay, well, here now we're understanding the implications of the ACE study, and what are the next steps for us? And based on our skills and interests of our staff as we respond to these client needs and characteristics and the local resources around us, how do we integrate that research with what's going to work here? And researchers, I think, need to start to partner in a more community-engaged way, starting where agencies and communities are at, to look at the services they're pulling together in terms of ACE response and the outcomes that they're looking for. So basically, that's my overview of next steps. So I want to thank you very much, and I look forward to questions and discussions as we move along. There are provider tools, too, on posttraumawellness.net. Thank you.
Okay. Good morning. My name is Christina Bethel, and I didn't realize I have pointers and this and my glasses, so it'll be an interesting journey through the next few minutes. First of all, I want to thank Jane Stevens for, I don't know where she is in the room, but I just want to thank her for connecting with me and putting me in touch with Martha so that I could present and share with you this morning. And the title of my talk is National and State Data on ACE Risk and Resilience, the Call for Mind-Body Interventions, but the real title of my talk is Healing is Upon Us, and I want to tell this a little bit as a story. So once upon a time, there was a fortunate and very courageous group of souls, all of whom are in this room, who lived in a time when science and policy and our lived experience met. And we have a lot of science now that teaches us about our linked lives, where we're relearning that health is a function of both establishing, maintaining, and as needed, recovering connection, both within us, between us, and around us. And in addition, we really learned that we could do something about this in policy, and the CDC in 2008 began talking about this as a result of the great work that's been shared already here today, and the American Academy of Pediatrics putting a policy statement out on toxic stress for pediatricians. And then, of course, there's the great science, including interpersonal neurobiology, the increasing science on mindfulness, as was mentioned earlier, that are all supporting interventions and ways to get up underneath this. So we're living in a fortunate time. The economists are listening. I have to put this up here because Jim Heckman was one of my professors at the University of Chicago. When I was there, he thought I was crazy, but not anymore. And where we really know the long-term consequences of ignoring socio-emotional development. So I am in a very privileged place today to present to you that we actually, we're adding to this wonderful confluence of the story about how healing is upon us with some national data on ACEs for children. So I am going to be presenting this data, which actually comes from the Maternal and Child Health Bureau in the U.S. Department of Health and Human Services, Health Services and Resources Administration, where years ago we got together and tried to make sure that we put information on ACEs and resilience, as well as family connection and many other variables, in the National Survey of Children's Health, which is a national representative population-based survey at the state and national level. So what we find here is that about half of children nearly experience one or more of 9 ACEs measured, and about 23% are experiencing 2 or more. And this varies across states quite a bit, so maybe where we live and what we do matters and has an impact. So this variation is information for those of you who are into statistics. That's good. We get to learn. There's a lot of data available for you today if you want to query it at childhealthdata.org, where you can go to find the data on your state for subgroups of children in your state in a query. So I'm not going to go through how to use this tool, but you can today access this data. So let me just tell you a little bit about what we found. First of all, about 47%, as I mentioned. Is there a pointer up here that works? This one. That was actually, yeah, okay. Had experienced one or more, with it ranging from 40 to about 57% across the U.S. states. So that's the variation. And then 2 or more is 23%, with a range of 16 to 33. And then these are the adverse childhood experiences that were actually assessed, with an important point that questions about child abuse and neglect were not directly asked about, like sexual abuse, for obvious reasons, but it really shouldn't change to substantially different overall rates, since there's so much co-occurring ACEs, as was mentioned earlier. So this is the punchline for that. And then the variation across groups is significant, and as expected, across income groups, as well as race, ethnicity groups. So we have this information now. We have disparities in disparities, where being in a disparity group in one state is different than being in a disparity group in another state, and that's, again, information about what's going on in Oklahoma and how is that showing up in the data. We know that this works because developmental screening was a measure, and we measured it in 2007, and it's increased in 2011-12 because of what states are doing, and the states that it increased in are the states that are really focused on it, so that we know that state policy and programs are reflected in this national data. So obviously higher rates in older children with more opportunities to accumulate ACEs, and higher rates, but still keeping in mind that the rates are fairly high regardless of children, regardless of what socioeconomic group they're in. And we've already talked about compounded risks, that there's a catch-22 perhaps between ACEs and the health and stress of parents, with about 36% of mothers having less than very good or good physical or mental health when their child experienced 2 or more ACEs. And, but again, keeping in mind that we have a long way to go for all children improving the health of mothers, and that the health of mothers, as was mentioned earlier, is very key to the health of children and families, and that this is an important thing to combine. In terms of other aspects of ACEs and home, school, and community well-being, there's this protective home environment, which is actually really just looking at smoking in the home and things that aren't really income dependent, connecting with the child, reading with the child, having conversations with your child, being extremely low for children who experience 2 or more ACEs, 1 or more, but again, still being much lower than they need to be for all children. And then also protective effective resilience. So whether resilience is built early or over time, and this is a cross-sectional survey, so we need to keep that in mind, that among children who experienced ACEs, those who were able to develop a certain amount of resilience in being able to be calm and control when faced with a challenge, were much less likely to miss a great deal of school, which puts them at risk for repeating grades. And also who were able to stay engaged in school and participate in activities, and this is quite a big jump. So these are children who are equalized in terms of other aspects of risk, but who nonetheless somehow have been able to develop resilience. So this is, I think, what you already know, but it's nice to see it in a national, hopefully state data set. So this is really looking at what I call our chicken and egg observations, given that this is cross-sectional, where adverse childhood experiences are associated with higher rates of chronic conditions, and in particular emotional, behavioral, and developmental problems. Not a surprise, but hopefully empowering for states to begin to use this data in a policy context and in a practice improvement context right away. That in fact what we think is true and know is true is actually true, it looks like. So that's helpful, right? So children with special health care needs, much more likely to experience 1 or 2 ACEs, and then children with special health care needs who also experience emotional, behavioral, developmental problems, which is about 9% of children nationally, are 70% experiencing 2 or more ACEs. Which, if you look at it, starts to look causal when you look at the more extreme ACEs that these children are reported to have experienced, whether some of them are poverty, that's hard, but this is what some might call more extreme ACEs around being a victim of violence or witnessing violence, seeing parents, domestic violence situations, and living with anyone who's mentally ill, suicidal, or severely depressed, being much higher for children who experience emotional, mental, and behavioral problems, with 43.5% of these children having parents who report usually or always feeling aggravated with their child, keeping in mind that this is a very big optimistic report for a parent to report on a telephone with a CDC interviewer that I am usually or always aggravated with my child is probably going to be an underestimate. So when you see that for this subset of children, they're actually acknowledging that that's how they feel, and then we know that how that resonates back and forth into building low self-esteem on top of low self-esteem. So it starts to look predictive, and it leads me to want to bring together the evidence around what's possible in terms of starting to do healing before it leads to psychotropic drugs and before it leads to interventions where the safety net before was discussed at the bottom and start to get at the top. And it seems to me there's some promising modalities related to mind-body methods because of their effectiveness in promoting integration of the brain, development of resilience, and executive function, and other things that many people in this room already know about. And for those of you who know Bessel von Klock, he gave a talk a couple weeks ago that I participated in where he said, without mindfulness, there is no therapy. Without mindfulness, there is no growth. So there's this fluoride in the water concept called mindfulness, which was talked about before, which is really the capacity to be present, and that's actually a brain function, not a moral characteristic. And it seems to be a cross-cutting attribute of many of these mind-body modalities where we're seeing more and more research studies coming out around the effectiveness for toxic stress. So what we see is a very low prevalence of children using those modalities, about 5%, and much lower in lower income groups where we need to. If you look at specific health conditions, it's higher for depression, anxiety, or stress, but it's still fairly low. And again, if you compare the evidence on psychotropic drugs and stimulants and other things and the mind-body, they start to look like they're safe, and we need to make an argument or an assessment of what needs to be done. So ADHD and trauma, as Bessel von Klock would say, is it ADHD or is it toxic stress? So it's not really clear which it is. They couldn't really get a DSM category for toxic stress, which they tried to do, and he's working with 120 organizations across the country to continue that because it gets clocked as PTSD. And when he has been working with children, it looks like there's a lot of trauma embedded in this diagnosis. So this is just an illustration where I linked the data from the National Health Interview Survey to the Medical Expenditures Panel Survey, looking at treatment, mind-body therapies for children with ADHD was around 15%. Taking drugs for concentration was 68 and about 67 for hyperactivity. And when you look at the economics of this, that by the time children get into these sorts of modalities, their healthcare costs are already much higher than for other children with similar conditions. And if they have those emotional, mental, behavioral problems that I mentioned before, their healthcare costs are almost $6,000 a year, with the average being about $900 for a child. So they're getting into these modalities, but at a very late stage, again, really supporting what you were talking about earlier about the safety net being really at the bottom, not at the top. So there's an overview of this in your on the website, which put together a data brief just for all of you today. And also, Jane Stevens has published a lot of this data on the ACEs connection this morning. I want to encourage you to go to the Data Resource Center. And I also, to get the data, and I also just want to end with, again, saying that healing is upon and between us. And if I have 1 minute, I want to read you, I actually have a couple minutes. I went quicker than I thought. So I just want to end by saying that I had the opportunity and the blessing, really, for the Maternal and Child Health Bureau to ask the initiative that I run to do a national set of interviews on really looking at how to bring forth the life course theory into a translational framework in America, and many other people in the country are working on that as well. But I had this little opportunity to interview a lot of people. And I had worked with people for 15 years, and we didn't know each other's stories. So I just started asking people an appreciative inquiry about their stories as a basis to then translate into what do we need to do to bring this into pediatrics, to bring this into training, to bring this into the systems that we already have. And what I came up with was a very important need for us to share who we are in this. And also a poem came out of it that I'm going to recite to you. And it's called Improbable Few. Let me just gather my frontal lobe. Okay. Improbable people always lay low. They take short sips and never throw fits. There are things that only they know. Like love is real, yet hard to feel, when the screen was so blank and only God to thank for that nightlight hung on the soul. Research would say they shouldn't be this way, but love sprung out their improbable outspout until eventually even they ran dry. Improbably then, the real journey begins, held down with a howl and inspout installed, pain rising up to be skimmed. So they start having fits and taking long sips, and people smile wide. God beams with pride, held strong in the love that they grew from that place that already knew these, the improbable few. And I would just like to say that I think healing is upon us to take it from the improbable few to the improbable many. Thank you.
Well, how do I follow that? Hi, I'm Lee. Welcome. I'm Lee Pachter, and the next three talks are going to be talks from participants at the Philadelphia ACE Task Force. One of the goals of the Philadelphia ACE Task Force was to look at adverse childhood experiences from the urban perspective. And one of the activities was to address the question, are there adverse childhood experiences or potentially toxic stressors that are unique to specific contexts? And by context, we mean things such as poverty, social class, minority status, or race ethnicity. These are obviously all interrelated, but they're separate. Obviously, the initial work on adverse childhood experiences was amazing work. It was done in a specific social context, and what we're dealing with in Philadelphia in some ways is similar, but in a lot of ways is different. And within these contexts, does the exposure to multiple ACEs or potentially toxic stressors not only quantitatively but qualitatively change the consequences of any one adverse event? I mean, we have an ACE score, which is basically a cumulative score. I think that that's really good, but as we identify more potential adverse experiences and stressors, are there some qualitative interactions between the stresses, which is more than just numbering, 1 through 5 or 1 through 10 or 1 through 15? Now, are there potentially clusters which may interact with each other with regards to their salience together or with regards to outcome? For me, having one adverse experience would be totally amazing and probably difficult to get over. But in the context of a child who's dealing with 4, 5, 6, 7, 8 experiences on a regular daily level, and in addition is experiencing things such as bullying, witness to violence, discrimination, etc., are there qualitative differences in how people conceptualize and process some of these experiences? We haven't answered that question yet, but what we are working on is how can we think about other potential experiences which may have adverse consequences for children and adults in the urban setting. And I'm here today to discuss one specific adverse experience or potentially toxic stressor, which is racial and ethnic discrimination. So a lot of different definitions, but one for racism is the beliefs, attitudes, and actions resulting from categorizing individuals and groups based on phenotype, heritage, or culture. There is a very small but pretty significant literature showing that perceptions of racism does affect children's health. Not a lot of papers, there are about 40 in this review done in 2009. And it shows that perceptions of racism have been associated with health conditions such as prematurity and low birth weight. That's obviously perceptions of racism of the mother. Actually, one study showed that if you take discrimination into the mix, the black-white difference in low birth weight and prematurity may become insignificant. So it's a potentially strong variable. But with regards to kids, there have been some studies that have shown that discrimination has been associated with poor cardiovascular health, metabolic disease, and specifically with behavioral and mental health issues. Includes depression, anxiety, tobacco, alcohol, and substance use, and other adverse behavioral consequences. Only 70% of these studies were done on one minority group, African Americans, and most of them used instruments that were specific to adults. So the literature wasn't that great. So we decided to study discrimination and racism in a little bit more, in a manner that was more specific to children of multiple ethnicities and multiple developmental ages. So we developed a questionnaire where we basically asked kids about their experiences with discrimination. I'm not going to go through all of these, but as you can see there, we spoke with kids qualitatively and found out different contexts where kids may have felt like they were discriminated against. Walking around a mall or a store and being followed around by security guards or store clerks, getting poor service, being treated unfairly by police officers, at school being called down to the principal's office, getting grades you didn't deserve. You had the feeling that someone was afraid of you. Someone called you an insulting name. People assume you're not smart or intelligent. Or have you ever seen your parents or other family members experience any of these situations? We got this information from talking with kids, and we put it into a questionnaire. And we asked kids specifically, of these 23 questions, we later on developed a 10-item instrument, which is psychometrically valid and reliable. But for each of these questions, we asked, well, first of all, we asked people, this is how we introduced it. When people are racially discriminated against, they're treated badly, not given respect, or are considered inferior because of the color of their skin, because they speak a different language or have an accent, or because they come from a different country or culture. And for each of those situations, you tell us whether you've ever felt discriminated against because of these reasons. And if they answered yes, we asked, has it happened to you? Yes, how often? So we get to chronicity. Why do you think it happened to you? Attribution. How did this make you feel? What your emotional response was. And how did you deal with it, which is the coping response. So we asked 277 kids in 2 cities in New England, Hartford and Providence. The breakdown was most of them were Latina or Latino, and Puerto Rican specifically. 31% were African American, 7% were Afro-Caribbean, and 19% were multicultural, multiracial. This just speaks to the importance of disaggregating the data. You know, we usually use census-level data, you know, black, white, Hispanic. We need to go a little bit further, especially when we're talking about such potential toxic psychosocial stresses where people may experience them slightly differently. So, pop quiz. Of the 277 kids that we interviewed, how many do you think experienced at least one of those situations? 18%? Who says 18%? 34%. 66%? And 88%. Wow, you guys are good. 88%. 245 of the 277 kids we interviewed perceived racial discrimination, at least one of those 23 items. The mean number of positive responses was about 25%, 6 of them. And 12% of the kids answered more than half of these questions positively, saying that they've experienced this. So I think we can say that discrimination and racism is a common adverse experience for many of our children. So I think the data here suggests that. We further looked to see whether perceptions of racism and discrimination were associated with depression. And we did find a significant relationship between racism and depressive symptoms in these children. We thought that we might have self-esteem as a moderator, and although there was a trend to it, it wasn't significant. But I think if we spoke with more kids, we might have found that out. So we try to think of a model on how racism gets under your skin, basically, and contributes to adverse childhood experiences and adverse health consequences. So you take a social stressor such as racism, and this is just one. You add some of the potential things which may moderate it, things such as their perception of where they are in social class, what their coping responses are, and how parents kind of address racial issues in the family. There's obviously a response to this social stressor, whether it's physiological or psychological. This contributes to what we heard about earlier, allostatic load or physiologic dysregulation. The idea that chronic stressors, whether it's racism or child abuse or whatever else, unbuffered and unremitting, can cause actual physiologic dysregulation in the homeostatic mechanisms in the body. And these are just 3, hypothalamic pituitary adrenal dysregulation through cortisol, SMA dysregulation, which would lead to cardiovascular reactivity and decreased arterial elasticity, altered inflammation, immune response. There are many of them. And then this would, over time, lead to increased morbidity in things such as cardiovascular disease, asthma, obesity, diabetes, depression, etc. Because all of those conditions have some dysregulatory component to its pathophysiology. It's kind of interesting that these conditions are also the conditions we see that we have racial and ethnic disparities in chronic disease, right? Minority adults have higher cardiovascular disease, diabetes, obesity, asthma, depression, etc. So we may be finding a process or a mechanism through which psychosocial stressors may contribute to racial and ethnic health disparities later on down the line and in childhood. And we're actually gathering some data now to suggest that this may be true. So what we're doing is we're actually interviewing African-American adolescents, and we're looking at their level of perceptions of racism, and we're taking salivary cortisol levels to see whether their cortisol slopes have changed. As all of you may know, this is going back to Physiology 101, this is a typical daily cortisol slope, where in the morning when you wake up, it starts relatively high, it bumps up in the first half hour, and then throughout the day, it goes down. This is normal, this is physiologic. Well, let me show you a slope of one of the kids that we've interviewed so far. This kid starts his day at a much, much lower cortisol level. He does have that bump, but if you think of this slope of the black line and the slope of the red line, we see dysregulation here. It just so happens that this child answered 7 of the 10 questions on racism as an experience. So we're going to hopefully address this with a lot more kids, but we found a positive correlation between number of discriminatory events and cortisol dysregulation. And hopefully, as you know, racism is just one of a number of different psychosocial stressors which may potentially be toxic stressors. Because of this type of research, we decided to add racism into our questions as we were talking to kids in Philadelphia and adults in Philadelphia about potential adverse childhood experiences. I think our next speaker will take it up from there. Thank you.
Thank you. Hi, I'm Mary Harkin-Schwartz, and I'm here today to present the findings from the Philadelphia Urban ACE Survey. There we go. Thanks. So as Lee mentioned, some of the background of the Philadelphia Urban ACE Survey and the work that we're doing is, as has been discussed numerous times today, the research has shown that the prevalence of ACE is very high, or is pretty high among the general population. But there has not been a lot of studies to look at an urban population in particular. And so what we wanted to do, the purpose of the background for this study was to look at ACEs in an urban environment, and in this case in Philadelphia. Also, research suggests that growing up and living in an urban environment has some stressors that are not necessarily captured on the ACE score. So stressors just growing up from your community, whether you feel safe, whether you experience racial discrimination in an urban environment where there's more of a mix of ethnically and race diverse population. What, as Lee just explained, are they experiencing racial discrimination? And so we wanted to try to develop measures that could look at those things and try to measure the community stressors that people may be experiencing. And so the ACE Task Force and Institute for Safe Families decided to develop this Philadelphia Urban ACE study to measure these items. And as I said, the purpose of the Philadelphia Urban ACE study was to look at the prevalence of ACEs in an urban population, in this case in Philadelphia, to develop an urban ACE score to measure community and neighborhood stressors. And this work was funded by the Institute for Safe Families through a grant by the Robert Wood Johnson Foundation. And where I work, the Research and Evaluation Group at Public Health Management Corporation conducted this study. What we did for the study is we built on work that PHMC already does. PHMC conducts a large household health survey in southeastern Pennsylvania with over 10,000 households. It's done every other year. It's a telephone survey. And we speak with adults in households and gather a whole host of information, a broad range of topics such as health status, chronic health conditions, access to health, health behaviors, and health screenings. Interviews are conducted by telephone, and they use a dual-frame random digit dial. We were able to follow up on this household health survey and telephone Philadelphia residents. So this past summer, this household health survey was conducted, and we did a follow-up survey just looking at Philadelphia. And we were able to build on, and we didn't need to collect, again, the demographics or the health outcomes because they had already been collected. And we didn't need to develop a new sample frame because that had already been done. So as I mentioned, it was a telephone, a follow-up survey. We spoke with 1,784 respondents. Our response rate was 67%. The survey data were demographically weighted to be representative of the Philadelphia population. And the questionnaire was designed by the ACE task force along with PHMC. And we built on the work, of course, that's already been done from the ACE-Kaiser study, Dr. Anda, the BRIFIS, the Behavioral Risk Factor Surveillance Survey, as well as the international urban ACE questions that have been used. And then, of course, we built on the work that Lee and Roy are doing and what the ACE task force had also brought to the table, things that they thought were important to try to measure in an urban population. And this slide shows just the demographic characteristics of, this is not weighted, but these are the demographic characteristics of the survey respondents. So you can see, as typical, the women were more helpful than the males. So 58% of our respondents were females, 41% were males, 35% were college graduates, 30% were between 18 and 34 years of age. And race and ethnicity, we had about 45% white non-Hispanics, 43% black or African American, and then about 3% for the other race and ethnic breakdowns. So now I'd like to go over our findings, and I'll start with what I call the standard or traditional ACE indicators. Oops, and I jumped to, sorry, I noticed last night I messed up one of the orders of my slides, sorry. So we'll start with the verbal and physical child abuse. And if you look at this slide, the light blue represents the adverse experience occurring more than once, and the darker blue represents the adverse experience occurring once. So if you look at the first to your left, those two columns are verbal. While you were growing up, did you experience someone swearing at you, insulting you, or putting you down? And you can see 30.6% of Philadelphia adults grew up in a household where a parent, step-parent, or another adult swore at them, insulted them, or put them down more than once. 16.8%, the next two columns, of Philadelphia adults grew up in a household where more than once an adult in the household acted in a way that made them feel afraid that they would be physically hurt. 33.1% of Philadelphia adults reported that more than once they were pushed, grabbed, slapped, or shoved by a parent, step-parent, or another adult in their home. And 13.8% were hit so hard that they had marks or were injured. This slide shows our measures for child sexual abuse. 15% of the Philadelphia adults were touched, fondled as a child in a sexual way, or had an adult touched, or were touched an adult in a sexual way. 8.1% of Philadelphia adults experienced during their childhood someone attempting to have or actually having sexual intercourse with them. Now I'd like to move on to our measures of child neglect. And for the Urban ACE survey, we defined emotional neglect as whether someone in your life made you feel important or special while you were growing up. 7.7% of Philadelphia adults rarely or never had someone in their life who made them feel important or special. For the Urban ACE study, we defined physical neglect as whether growing up your family cut the size of meals because they didn't have enough money, cut or skipped the size of meals because there wasn't enough money for food in the budget. 19.1% of Philadelphia adults grew up in a family where sometimes, often, or very often, their family cut the size or skipped meals because there was not enough money. And these measures on this slide look at household indicators for household dysfunction. 23% of Philadelphia adults grew up in a household where someone was depressed or mentally ill. 7.5% of Philadelphia adults grew up in a household where someone was suicidal. 27.4% of Philadelphia adults grew up where there was substance abuse in the household, a problem drinker or alcoholic. 16.5% grew up in a household where prescription medications were abused or illegal street drugs were used. And 12.9% grew up in a household where someone served time in prison or was sentenced to serve time in prison or jail. This slide, again, is another slide for household dysfunction, and it's looking witnessing domestic violence in the household. And the first columns on your left are verbally abused. Light blue is many times, turquoise is a few times, and dark blue is that the experience happened once. 15.1% of Philadelphia adults saw or heard in their home their parent, step-parent, or another adult caring for them be yelled at, screamed at, insulted, or humiliated many times. 29.1% saw or heard it a few times. In the middle is witnessing physical abuse, and again, 6% heard or saw their parent, step-parent, or another adult being physically abused, slapped, kicked, punched, or beaten. 11.3% saw or heard it a few times. And 1.8% saw or heard in their home their parents or other adults being physically abused with an object. That's on the right-hand side. And 4% saw or heard that a few times. So on this slide, what we wanted to do was compare our findings to the behavioral risk factor surveillance system. And Dr. Anda, you can add Pennsylvania to your slide that you showed earlier. I believe we have someone here from the Department of Pennsylvania's Department of Health here today. In 2010, Pennsylvania did add the ACE module to their BRIFIS survey. So what we did is we have 3 columns here. We have our findings from the Philadelphia Urban ACE survey. In the middle, we have Pennsylvania's BRIFIS from 2010. And then on the right-hand column, we have the BRIFIS from 5 states of Arkansas, Louisiana, New Mexico, Tennessee, and Washington. 5 minutes, wow, okay. And what we did is we did on this slide, we did compare our findings to those states, looking at the confidence intervals and be able to tell whether they're significantly different at 0.05%. And there's one thing I should point out, that our definition on this slide for physical abuse and witnessing domestic violence are slightly different than I'll present on the rest of the slides, and that was to make this just as much of an apples-to-apples comparison. And feel free to follow up with me afterwards for a further description. But you can see that for almost all the measures, we are higher, and that's statistically significant, than when you look at Pennsylvania and the 5 states. The one that we're similar is verbal abuse. For Philadelphia, 30.6% of Philadelphians experience verbal abuse, and that's similar to Pennsylvania, where there was a report of about 30%. But on all the other measures, we're higher. The other thing I just want to point out is physical abuse. If you look at Philadelphia, 45.9% of Philadelphians reported physical abuse while growing up, and that's much higher than what's reported on BRIFIS for Pennsylvania and the 5 states, which are about 13 and 14%. And the thing that's interesting about that is BRIFIS included a caveat to their question, which said do not include spanking. And we did not include that. And so I think this raises the question, is this measuring spanking or what people equate with spanking? And then that goes to, well, what do you think about that? Do we think spanking is okay or not? And I don't want to, because I'm running out of time, I won't spend too much time on this slide, but we had a similar trend when we compared our data to the Kaiser data. And this is the Wave 1 and Wave 2, which is on CDC's website. In general, we found higher childhood adverse experiences for emotional and physical abuse and physical neglect compared to Kaiser, but lower reports of sexual abuse and emotional neglect. And when you look on the next slide for household dysfunction, we were higher on all of the measures compared to the Kaiser study. And so now I want to get into our urban ACE questions. And these are the additional questions that we asked to try to measure the community experiences, and that saw violence, felt discrimination, growing up in a diverse neighborhood, being bullied, and living in foster care. 40.5% of Philadelphia adults saw or heard violence. That is, a few times they saw or heard someone being beaten up, stabbed, shot in real life. 34% were treated badly, reported that they were treated badly or unfairly because of their race or ethnicity. And when we looked at, when we broke that down, looking at your race and ethnicity, definitely we found that those who were African American, biracial, felt more discrimination compared to white non-Hispanics. 27% had an adverse experience in regard to their neighborhood. That is, they did not feel safe in their neighborhood, or they felt people in their neighborhood did not look up, stood up for each other, or could be trusted. 7.9% were bullied by a peer or classmate, and 2.4% lived in foster care at some point. This slide shows the distribution of ACE scores. The light blue are the traditional ACE, and the dark blue are the urban ACE. And because the urban ACE includes more questions, you can see that if you look all the way to the right at 4 or more, there are more people who have 4 or more adverse experiences. There's more questions, so there's more of a chance to have 4 or more. Overall, 37% of Philadelphia adults experience 4 or more on the urban ACE scale, and this represents 432,000 Philadelphia adults. This slide shows the demographic predictors of Philadelphia urban ACE survey respondents. And we found statistically significant differences on all of our measures. What this shows, if you look at that top line, among males, 41% had 4 or more urban ACEs, and among females, 34% had 4 or more urban ACEs. So ACEs rose were more likely among those who were who were below 150% of the poverty guideline. Among our younger 18 to 34-year-olds, among those with less than a high school or less than education, and were higher among those with who were Black or biracial or multiracial. And these slides, because I'm running out of time, I think, 2 minutes? All right. I actually can go fast because we've replicated and found what's been found before. As the ACEs increase, as your number of ACEs increase, different health behaviors or poor health behaviors are more likely. So as you can see, the dark blue are people who had 4 or more ACEs. And people with 4 or more ACEs are more likely to be smokers. And we broke this down, we controlled for poverty. So on the left are people who are below 150% of the poverty level, and to the right are people who are at or above 150% of the poverty level. So as you can see, it's been shown before, there's a dose-response relationship. Same thing when we looked at depression, we saw the same relationship. And again, that held true when we controlled for poverty. And again, the same thing when we looked at whether you were diagnosed with a mental health condition. And we found this same relationship when we looked at other measures, when we looked at suicide, when we looked at substance abuse, having a high number of sex partners. Oops, sorry. When we looked at health outcomes, we started to look at that, and we looked at cancer, heart attack, diabetes, and when we used our urban ACE score, we did not find the dose-response relationship, and we didn't find statistical significance. And I think that I put on my tag opportunity. I think this data set is very rich, and there's a lot of opportunity for us to look into this further. So I think there's more work to be done on our urban ACE score and to see what measures we want to include in a final analysis of it. There may be some measures that we would take out in our analysis. So what I did for the next 2 slides is I went back to that standard ACE score, the 9 items. And we did find statistical significance for those who are at or above 150% of the federal poverty level when we looked at ACEs and cancer. But you can see we didn't find exactly our dose-response relationship because the people who had 1 to, if you look at that middle group, the people who had 1 to 3 ACEs were more likely or had higher number of, were more likely to have cancer than the other respondents. But again, this is an opportunity. What this slide suggests to me is that we have more work to do. At the time when we did this analysis, we did not control for a number of possible confounding effects, such as age, race, sex, and educational attainment. So we have more work to be done. And that's true on this slide as well, heart attack. And so finally, just in conclusion, we did find that there's a high prevalence of ACE in the community, and this was higher than compared to Griffiths and compared to what had been done for Kaiser. And we did find a high prevalence on our urban ACE questions. Having 40% of the population have seen someone beaten, stabbed, or shot is just shocking to me. And so, as I said, opportunity again. This is a rich data set, and then we'll continue to do analysis on. I'm happy to answer any questions afterwards, and if you have any other questions, I know Martha would also be happy to answer them. Thank you.
So I'm going to call out Steve Berkowitz, who was in many ways the author of this project, for leaving right when I'm presenting this work. I'm happy to be here. I want to thank ISF for giving me this opportunity to talk about my qualitative study trying to conceptualize adversity in low-income urban settings. So I know that we're all experts on the Adverse Childhood Experience Study, but just to give you guys a background and framework on how we designed and why we built this project, the Adverse Childhood Experience Study looked at the association between several childhood exposures broadly defined in the domains of abuse, neglect, and various forms of household dysfunction, and in that with adult health outcomes. This work has shown that children who have these exposures are at increased risk of poor outcomes throughout their life course, starting in infancy and going into senescence. But when you think about the neighborhoods within Philadelphia, these experiences in some of our neighborhoods are more common, but they don't adequately capture the broad ranges of adversity that children face in these communities. This point is probably best highlighted when looking at the differences in the demographics between the ACE study population and our population here in Philadelphia. Our population in general is younger, more diverse, less likely to have higher levels of educational attainment, and therefore more likely to be in poverty. And what we're saying is that these factors actually can predispose our population to a broad range of adversities that aren't captured in those measures. So what did we want to do? We wanted to understand and conceptualize from a community perspective what these adversities may be. Our specific aims were to use focus groups to identify and characterize the range of adverse events experienced by low-income urban youth, and then describe the relative significance of these adverse experiences in this population. So our overall study design was to use focus groups with young adults ages 18 to 26 who grew up in Philadelphia. We used a nominal group technique to ask these participants their personal experiences of adversity or those seen by individuals or those experienced by individuals in their neighborhoods. We developed a list of these experiences and then asked our participants to rank those by the relative significance. We then took that final ranked list of all of our focus groups and analyzed it and developed domains of adversity, which were ranked by the number of times they were endorsed by our participants. We then took that list back to our community and asked about contextual issues surrounding these experiences. Our study participants were individuals aged 18 to 26 who spent at least half of their life prior to age 18 in the city of Philadelphia. And we particularly targeted low-income communities and low-income people who lived in low-income neighborhoods, which we defined as communities with at least 20% of the residents at or below the federal poverty limit. So we work with a number of organizations which target their services towards youth and young adults who are living in economic distress. These programs include the youth mentoring programs, shelters, clinics, and schools. What we have here is a map of the city of Philadelphia, and we use census data from the year 2000 to show poverty rates by neighborhood throughout the city. The darker areas are areas where there are higher rates of poverty, and the stars indicate places where we held our focus groups at. As you can see, we held focus groups at in many of the most economically distressed areas in the city. Our general demographics, we held 19 focus groups with 119 participants, the majority of which were male, African American, and lived in extreme economic distress. And this shows the list of domains listed from most commonly cited to the least commonly cited, starting with family relationships, community stressors, and personal victimization, which included the measures of abuse and neglect, but also other forms of criminal victimization that young children can experience, economic hardship, peer relationships, discrimination, problems within the school and in the healthcare system, involvement in the juvenile and child well justice systems, and media and technology. Now, what I want to do now, since I have limited time, is focus on a few of those domains to give you some of the context around what our participants said. So starting with family relationships. Now, every measure of household dysfunction that was included in the initial ACE studies was endorsed by our participants. But what we found was that our participants cited broader experiences around the lack of support within their homes and limited parental guidance. One of our participants said, "My mom said I ain't teach you nothing because I want you to go through the same thing I went through. It's just like heartless, like you just don't care. My parents couldn't show me love. They made me feel like I was just a check." In terms of community stressors, so these were experiences around violence within the community and death within the community, or persistent negative adult behavior, or exposure to neighborhood nonviolent crime. One participant summed it up in this way: there were shootings every night, so much so that kids couldn't play outside. You wake up in the morning and find that someone from your friend's family passed away. Now, in thinking about economic hardship, what our participants said is they could feel the pressure that they could feel the lack of money within their families, but also they felt the lack of resources or seeing their parents struggle to make ends. One participant said, "The hardest thing for me was watching my mom struggle financially to pay for food, utilities, and bills." And then the final domain we'll look at today is discrimination. And here, our participants cited feelings of being stereotyped or racially profiled. One participant said, "Stereotyping. It's mostly white people. The way they look at you when you're walking in the street, they try to downgrade you. I've seen people follow black people around the store. They already got a mindset about us before they even know who we are." So what are our key findings? So first, while our participants endorsed every one of those measures from the initial ACE studies, they cited broader experiences of adversity that were not included in those studies. In terms of the family dysfunction domain, which was the most commonly cited experience, they listed the experiences of household dysfunction, but also when we pressed them about the contextual issues around that, they said it was really about the lack of love or lack of support or poor parental guidance that they felt within their homes. We also noted that instead of talking about divorce and separation, many of our participants cited living in single-parent homes. When we asked them contextual issues around that, they said that so many of their families start off as single-parent homes that the idea of divorce or separation is something that's foreign to them. Another commonly cited stress was economic hardship and the lack of safety. But lack of safety was primarily through, one, experience of personal victimization, but the experience of negative behaviors within their communities. And then finally, we were actually shocked given the high number of racially diverse individuals who were in our focus groups that racism actually was so lowly endorsed by many of our participants. And then very few participants endorsed corporal punishment or harsh parenting as a significant stressor. So what are the implications? As we think about assessing for ACEs within our practices, we need to think about the broader level or understanding what are the broader adversities that children face, and figure out ways to incorporate the community perspective in understanding what these are. We also have to understand that this is a complex issue that's surrounding development, timing, and also understanding how kids make meaning of their lives and what resiliency means for them. And then these need to be incorporated into the ACE framework to understand how they contribute to health outcomes. These are some of the general limitations, and I just wanted to take a moment to acknowledge my mentors, acknowledge the many organizations who work with me, and acknowledge the 119 individuals who were kind enough to share their experiences with me. Thank you.